Hello. So today we are going to discuss about non-Hodgkin lymphoma. Now just for the recap what lymphoma is all about. So first of all I would like to again just quickly recap what we have discussed in the last podcast. Lymphomas are basically malignancies of lymphocytes, that is B cells or T cells, and they often involve the lymph nodes. So inside the lymph nodes, when there is malignancy of B cells and T cells, and hence when they get swollen, we are saying that it's lymphomas. Omas mean mass. But point to be noted that lymphomas can, apart from lymph nodes, they can also occur in the extranodal sites like skin or GI tract. So again, how you will distinguish between Hodgkin and non-Hodgkin lymphoma is by the presence of the Reed-Sternberg cells um, in by performing the tissue biopsy. So if the Reed-Sternberg cells are present, yesterday which we have discussed, those cells which are just like we also say that owl-eyed or bilobed nucleus type of cells. So when they are present, we are saying it's a Hodgkin lymphoma, and when they are absent, so we will say it is non-Hodgkin lymphoma. So again, the clinical features through which we can differentiate between Hodgkin and non-Hodgkin lymphoma. So Hodgkin lymphoma can be localized, and in contrast, non-Hodgkin lymphoma often have multiple peripheral sites. Hodgkin lymphoma spread from node to node. In contrast, non-Hodgkin lymphoma spread in a non-contagious way, and extranodal involvement is rare in Hodgkin lymphoma, while in non-Hodgkin lymphoma, extranodal involvement is common, just like in GI tract or skin. So another point worth mentioning is regarding the Wildeye's ring, which is a lymphoid tissue in the pharynx. So usually in non-Hodgkin lymphoma, this Wildeyer ring is involved. However, in Hodgkin lymphoma, you will rarely see the involvement of the Wildeyer ring, which is the lymphoid tissue in the pharynx. As previously discussed, that lymphocyte antigens, specifically T cell associated lymphocyte antigens, are usually a single number digit right from CD1 to CD8. However, in B cells, usually we are having that double digit CD markers like CD10, 19, 20, 21, 22, 23. So when it comes towards the non-Hodgkin lymphoma, so first of all, we would just define the non-Hodgkin lymphoma that it's usually a B cell disorder. But yes, T cell malignancies are also found in the Hodgkin lymphoma. Non-Hodgkin lymphoma, according to WHO, there are more than 2 dozen subtypes, but today we are going to discuss the most common types which are relevant for the USMLE Step 1 and for medical school examinations. But just for the sake of understanding, we have to say that yes, they have got more than 2 dozens of the subtypes, and it is classified by B cells versus T cell disorder, regarding cell size and structure, small versus large cell, histological appearance, expression of the markers, immunophenotyping, or genetics. So these are numerous different ways through which we can classify non-Hodgkin lymphoma. But what today's podcast will be focused on some of the most common types of non-Hodgkin lymphoma, and let me name them one by one. One is the follicular lymphoma, other is the Marshall cell lymphoma, third is mantle zone lymphoma, fourth is diffuse large B cell lymphoma, fifth is small lymphocytic lymphoma, sixth is Burkitt lymphoma, seventh is adult T cell leukemia or lymphoma, and the eighth is cutaneous T cell lymphomas. So these all lymphomas come under the category of non-Hodgkin lymphoma. So let us briefly recap the structure of the lymph node. So as we all know that lymph node is comprised of a structure comprising cortex and medulla. So cortex is a very important structure, the outermost structure of the lymph node, and it contains in the outer layer some follicles. So the follicles are in the outermost cortex of the lymph node. Around the follicle, we will have a mantle layer, and around the mantle layer, we will have marginal layer. So the follicular lymphoma means that when follicles are increased in size and shape, mantle cell lymphoma arises from the layer above the follicle, and marginal zone lymphoma is the zone above the mantle layer. So cortex is usually an area in which B cells are matured, and paracortex, which is surrounding that cortex, usually contain T cells, and T cells are maturated in that paracortex. So first of all, we will discuss diffuse large B-cell lymphoma, which is the most common type of non-Hodgkin lymphoma. So how we will remember it, that it's basically a non-Hodgkin lymphoma, number first. Number second, it's a B-cell malignancy because it is expressing CD19 and CD20, which is a B-cell marker. And what it is doing, that it is obliterating the structure of lymph node due to enlargement of these B cells. So when there is malignancy, there is increase in number of cells, and what they will do, that they will obliterate the structure of the lymph node. So the median age and presentation of diffuse large B cell lymphoma is 64 years, and it's usually called age defining malignancy. So that's why it occur in HIV patients. Regarding the prognosis, it is having a variable prognosis, and the scoring method which is used for the prognosis is also called IPI score, or International Prognostic Index, in which we take into account age greater than 60 years, increased LDH, patient functional stages, clinical stage, and number of extranodal sites. So when we just take into account all these five factors and we just make a score, so we can just predict the prognosis of the diffuse large B cell lymphoma. So as we have said, that it is containing that CD marker CD19 and CD20, which is a pure B cell marker. So the drug of choice for diffuse large B cell lymphoma is rituximab, which is a monoclonal CD20 antibody. So monoclonal CD20 antibody is used in the lymphomas like diffuse large B cell lymphoma as well as in the follicular lymphomas. Now, follicular lymphoma, as is evident from the histological image, that follicles are increased in the follicular lymphoma. So, follicle, as we have discussed previously in the previously, that in the lymph node in the cortex region we will have the follicle. So, follicular lymphoma is also B cell malignancy, and it is having expression of CD19 and CD20, which are the B cell markers. But the genetic hallmark for the follicular lymphoma is the presence of 14-18 chromosomal translocation. The chromosome 14 is containing IgG heavy chain gene, and on chromosome 18 we are having BCL2 gene. So when there is a translocation between chromosome 14 and 18, so what will happen, that BCL2 will go near the IgG heavy chain gene. So as we all know that that IgG heavy chain gene is usually hyperactive. So what it will do, that when they will both merge, so BCL2 will also get overexpression due to overexpressing of IgG heavy chain. So what will happen, that BCL2 is a blocker of apoptosis. It's an antagonist of the apoptosis. So cell will start growing forever and it will become malignant. So germinal centered B cell usually lack BCL2, so that we all know that it undergoes somatic hypermutation, which we will discuss in much more detail in the immunology podcast. So B cells usually undergo somatic hypermutation during the process of infection or during the process of maturation, and by the way in which they are vanished off is through the process of apoptosis. So they usually lack that BCL2. So when they lack BCL2, what happens, that their apoptosis is comparatively easy. But when this translocation occurs, what will happen, that BCL2 and IgG heavy chain are in the same locus. So when they are in the same locus, what will happen, there will be an overexpression of the BCL2, and it will just antagonize the process of the apoptosis, and hence the follicles will start increasing in size in follicular lymphoma. The median age at diagnosis is 65 years, and it usually has that classical indolent course in which sometimes it appears and sometimes it regresses, which is called waxing and waning for years. Not all patients will require treatment because it's difficult to cure, And one of the feared complications of the follicular lymphoma is conversion into the diffuse large B cell lymphoma, and in which the diffuse large B cell lymphoma has a poor prognosis. Another thing worth mentioning is that how you will differentiate between the follicular lymphoma versus the reactive lymphadenopathy, the lymphadenopathy which occurs after an infection, because both have then increased in follicular growth. So what will happen that we have to distinguish between these both of entities, that whether we will say that it's a follicular lymphoma or whether it's a reactive lymphadenopathy. So in reactive lymphadenopathy, when there is an infection, so what will happen that B cells undergo somatic hypermutation because of some of them will mature and some will undergo that somatic hypermutation, and many will go into the process of apoptosis and will die away. So when B cells die away, so macrophages come and they just collect all the debris, which is called the tangible bodies, which are present in the reactive lymphadenopathy, as opposed to follicular lymphoma, in which we will not find these tangible bodies. So relative absence of the macrophages in the follicular lymphoma, however, in the reactive lymphadenopathy, you will always find the tangible body debris-laden macrophages. Then the BCL2 staining is also important, that in follicular lymphoma we will have that classical BCL2 staining, but in reactive lymphadenopathy BCL2 staining is absent. And in lymphoma, follicular lymphoma, the shape of the follicles will be similar to each other. However, in the reactive lymphadenopathy, there will be a varying size and shapes of the follicle. The third one is mantle cell lymphoma. So mantle cell lymphoma, as we have discussed in the structure of the lymph node, that mantle zone is above the follicle. Follicular zone, follicular above the follicle, the area around the follicle is the mantle area. So it's also B cell malignancy, and it arises from the follicle mantle, and it expresses also the B cell markers like CD19 and CD20. However, one of the important markers which is present in the mantle cell lymphoma is the presence of CD5. So it also co-expresses CD20 and CD5, and hence CD5 is an important marker of the mantle cell lymphoma. Median age at diagnosis is 68 years, and median overall survival is 3 to 4 years, and hence it shows a poor prognosis generally. So the translocation, just like in the follicular lymphoma, there is also translocation in the mantle cell lymphoma, but the translocation is of 11 and 14 chromosome, in which on 11 chromosome we are having that cyclin D1 gene, and it will translocate again to the 14th chromosome IgG heavy chain. So there will be an overexpression of the cyclin D1, and cyclin D1 promotes cell cycle transition from G1 to S phase, and hence increase in the mitosis and increase in the growth of cell will occur in the mantle cell lymphoma. Then we have discussed that above follicle there is mantle, and around the mantle there is the marginal zone. So marginal zone is formed in the lymph nodes after the process of inflammation, and usually the chronic inflammation generally give rise to this marginal zone. So it's also B cell malignancies and usually extranodal. So lymphoma and chronic inflammatory disorders, for example, in Sjogren's syndrome, in salivary gland, we are usually forming that marginal zone lymphoma. In Hashimoto thyroiditis, which is a chronic inflammatory disorder, we are seeing in thyroid gland this marginal zone lymphoma. And then when chronic H. pylori infection give rise to that maltoma in the stomach, it's also a form of marginal zone lymphoma. Then a word about small lymphocytic lymphoma, which we have also discussed previously, when we have said that when lymphocyte count is less than 5,000, we will say that it's a small lymphocytic lymphoma, but if it is greater than 5,000, we will say that it's chronic lymphocytic leukemia. So small lymphocytic lymphoma co-express CD20 and CD5 just like CLL, and it has similar markers to the mantle cell lymphoma, but in contrast to mantle cell lymphoma, it is typically negative for cyclin D1. Then we will discuss about the Burkitt lymphoma. It's also B cell malignancy, and it usually expresses CD19, CD20 just like all B cell originated malignancies. It's very aggressive, and it rapidly proliferate. So the key